Good evening. Thank you for joining the webinar brought to you by ASQ Innovation Division. Today's webinar is about innovation as a management response to disruptive experience from the front lines of healthcare policy reform. The Affordable Care Act is a disruptive innovation that healthcare policy experts are and will continue to grapple with for years to come. Rebecca will discuss how the use of innovation principles, tools, and practices is helping a team of Medicaid policy analysts respond more effectively to an environment of constant political and regulatory change. The learning objectives for this webinar are: learn unique challenges and opportunities to apply innovation in state government, challenge negative stereotypes of state government work and workers, describe how to translate innovation principles, tools, and practices into plain language that resonates with employees, managers, and teams, and help them craft effective, agile responses to shifting and chaotic stakeholder demands. Our presenter, Rebecca Anderson, is a PhD, MBA, and PMQ OE, a champion of healthcare, government, and nonprofit operational excellence. Rebecca is committed to bringing state-of-the-art management practices to those organizations that help, heal, and inspire others. Her expertise is healthcare policy analysis, regulatory compliance, process innovation, and organizational performance improvement. She holds an MBA degree with an emphasis in healthcare administration, as well as a PhD in counseling psychology. She is certified through the American Society for Quality, ASQ, as a manager of quality organizational excellence, and is currently serving as section chair of the Richmond chapter of the ASQ. So without further ado, let me introduce you all to Rebecca Anderson. Rebecca, please take it away.
Hey, thank you so much. It's so good to be here. Hello to everyone from Richmond, Virginia. I'm just tickled to be here and talk to you all about Medicaid, about healthcare in America, and about some of the solutions that we are deploying on the front lines with really the frontline policy, healthcare policy workers that are doing really the drudge work of trying to just catch up with all the things that are going on that you hear about in the headlines. Indeed, I am an operations manager. I work in the policy division for the Department of Medical Assistance Services here in Richmond, Virginia. And we are the state agency that coordinates Virginia's Medicaid program. And this is a program that assures access to quality health care for over 1 million poor Virginians. As your host just said, my professional background is healthcare administration. Most of my career has been spent in frontline healthcare in a hospital setting. My emphasis was in organ transplantation, and also have extensive experience applying the Baldrige program criteria. And you're going to hear vocabulary and sort of the paradigm of Baldrige woven through this presentation tonight. I have acted as examiner for other organizations, particularly on the state level, that are applying the Baldrige criteria. And also I'm a certified manager of quality and organizational excellence. Now you'll notice in my credentials you may see the PhD, and I am, that is in counseling psychology. And I often explain my function in organizations as a business psychologist. Essentially, I engineer people. And that's going to give you a little bit of my perspective as I begin my talk. Now, looking at this front slide, I'm hoping that you will recognize the image. I think most of you will. And if we were, if I was face-to-face with you all, I would be asking for hands to tell me who recognizes this image. And it is an image of Hogwarts. And where that came from, as I was preparing my slides yesterday, I had an interesting conversation with my 15-year-old son. And this led to a discussion of Harry Potter and the different personalities of the different professors and, at Hogwarts. And this is going to weave itself into the theme for my presentation, and you'll see why in a moment. So let's get started. All right, learning objectives. We just heard those. I did tweak them. As you all know, we all have to tweak our learning objectives as we bring our presentation under construction. but it hasn't changed substantially. We are going to talk about Medicaid's value as a source of health insurance for the poor in our country. We're going to summarize the crisis in U.S. healthcare. It's going to be critical that we do that because that frames the context in which our policy analysts work and the work that required some innovation that you're going to hear about. We're going to learn about the unique challenges and opportunities to applying innovation to Medicaid policy work, and describe how to translate innovation principles, tools, practices into the plain language that resonates with employees, managers, and teams, and helps them craft effective, agile responses to the shifting, crazy demands that are coming down on us right now. And you see up in the corner, that is the advanced textbook on potions making. All right, Chapter 1, we're going to talk about Medicaid. I want to make sure that we're all on the same page and that you understand what Medicaid is and what it isn't, okay? Medicaid. This is an assistance program that covers low to no income families and individuals. It is joint funded by the federal government and states. And a good mnemonic for you all, very likely you're sitting there, okay, what's Medicaid and what's Medicare? What's the difference? I can't keep them straight. And just think, give aid to the poor, okay? Let's contrast that to Medicare. It's an insurance program that primarily covers seniors, folks ages 65 and older, as well as disabled individuals who qualify for Social Security. It is an entirely 100% federal program. They take care of the elderly. I want to sort of dissect some of the verbiage here. Notice one difference is that Medicaid is an assistance program, where Medicare is an insurance program, essentially a single-payer insurance program. Medicaid is not single-payer. Perhaps you knew that, perhaps you did not. Medicaid in most states is increasingly a managed care program. What Medicaid does, it is the coordinator. It contracts with managed care companies like Anthem, Cigna, and so forth in order to contract with them to provide services, healthcare insurance to low to no income families. Now, states vary widely into the degree that they have shifted to a managed care model. In my own state, we are now about 85% of the services that we fund are provided through managed care companies for which we contract. There's variation across states. But that kind of gives you a picture. The Medicaid and Medicare are very different. The second thing you may notice, in addition to Medicaid is for poor, Medicare is for elderly, Medicaid is also a joint program, federal and state. Medicaid, we have to adhere to both federal and state laws and regulations. And as I mentioned, we are funded through a combination of money from the federal government and the states. And the current paradigm is that the federal government matches state spending. In Virginia, the federal government pays about 60 cents for every dollar spent on an enrollee in Medicaid in Virginia. Again, it varies across different states depending on the income level of the individuals, like the per capita income in states, okay? All right, Medicare is a straight insurance program. Okay, there's not necessarily a middleman, although there's some exceptions to that, but generally speaking, it's a straight insurance program. It might be helpful to know, given the current headlines, the current news that's out there. For example, Bernie Sanders just sponsored a bill where he talked about making Medicare the model for all. He is talking about a single-payer insurance program that is the government. All right. Moving on, continuing to talk about Medicaid, all right, aid to the poor. Every state has its own Medicaid program, but all total, all states combined, we cover about 70 million Americans, right? And that's about 1 in 5. which is pretty amazing when you think about it. All right, and 40% of those that covered are children, and they make up sort of the biggest population group covered. 1 in 3 births are covered by Medicaid. We have a very strong initiative across all states that we're very committed to finding women who are uninsured, who are pregnant, and getting them covered for their births. 2 in 3 residents in nursing facilities throughout our country are supported by Medicaid. 53% long-term services and supports, and what that's referring to, that includes folks in nursing homes, but it also includes people who are in the community who require long-term help but are still living in the community. They may be living in group homes, they may be living in private homes, but going to adult daycare programs, for example. Finally, behavioral health. Medicaid is the primary, the #1 payer for behavioral health services across the country. The total cost for Medicaid in our country is about $5.5 billion annually. And let's see, I'm looking at my notes here. Another thing you may wonder about is the Affordable Care Act and Medicaid expansion. Medicaid expansion has to do with states have the option of expanding Medicaid to more of their individuals, basically covering higher income levels. These folks are still making very little money and are still what we would call, poor, but they don't quite meet the hard line of Medicaid, so we have Medicaid expansion. Really kind of helps cover some of the working poor. Virginia, incidentally, does not participate. It's one of 14 states that elected to not participate as of 2017. What you may not know is Medicaid expansion, although it gets a lot of attention in the headlines, it's not a huge number of people. It's about 7 million folks. So about 10% of that number currently is are with this Medicaid expansion. Now, what you may not know is that when adjusted for health needs, okay, the Medicaid population in general are older, poorer, and more chronically ill and disabled. When you adjust for that, Medicaid costs less per capita than private insurance. Medicaid has a flatter cost curve, and I'm going to show you some graphs about that in a moment, which simply means the costs are increasing at a slower rate for Medicaid over time compared to private. Studies also show that access to health care, which is both timely, getting a provider to see you in a timely manner, is not significantly different comparing Medicaid to employee-sponsored insurance. And it is much, much better to no insurance. Now, when you see that Medicaid costs less per capita, there is a caveat. Medicaid pays providers less, and that's where those savings come from. So it's not all a rosy picture there. I told you I would show you about this bending cost curve. Medicaid enrollment and expenditures are slowing over time. I could talk all day about Medicaid innovation that's happening across the board, and it is amazing what we're doing in Medicaid. And that's why some of the headlines, some of the articles coming out now are saying Medicaid should be our model for health care in the United States, not Medicare, Medicaid. The tremendous initiatives going along in the area of payment, in the area of information technology, telehealth, ferreting out fraud, waste, and abuse are happening that are bringing costs down. So you'll see here on these graphs where the gray bar shows us 2015, these are federal fiscal years, 2016, and then orange is 2017 projected. What we're seeing here is that Medicaid enrollment has dropped, total Medicaid spending dropping, state Medicaid spending actually coming up a little bit. Some of that offset from federal to state is already happening. You may wonder why. How is Medicaid enrollment decreasing when we also have, coincidentally, the Medicaid expansion? Well, more people are coming off of traditional Medicaid as employment numbers improve, overall economy improves. So those are some hopeful results. And by the way, at the final slide of this presentation, I am going to have references that you can use, which includes a link to this information you're looking at now. Okay, moving on. Now, I've talked about Medicaid. I've given you a thumbnail sketch of what's going on in Medicaid and why I'm proud to be a part of it. Next, U.S. healthcare more generally. All right. Well, we know it is not a rosy picture. Unless you're living in a cave with no TV, no newspaper, no smartphone, you know that the U.S. healthcare system is in trouble. Many would call it a crisis, and I would agree that I'd say particularly in the last year, we have entered a time of crisis in U.S. healthcare. The crisis is because of cost. Our national spending, and I know you've heard these stats, but I'm going to give them to you again. National spending, 2013, 16.4%. Had it increased from 9.5% to 16.4% between the years of 1985 and 2013. If that rate continues, we'll be at 25% in 2015. And as a side note, there's a reason why I'm quoting 2013, and I'll tell you the reason in a moment. I know that data is a little bit old, but there's a reason. That's pre-Affordable Care Act, okay, and I'll come back to that. It's estimated if the rate in 2013 were to continue, it would be up to about 25% of gross domestic product. I didn't explain that. That's the percentage, is a percentage of our gross domestic product in 2025. As I already just showed you, in the Medicaid world, we're already bending our cost curve. We're already showing it flattening out and even decreasing in some areas. And this is without a block grant. This is based on the, quote, old model of Medicaid federal state matching based on need. All right, national spending on healthcare, $3 trillion. And when we compare ourselves with other high-income countries, that's where it gets disturbing. We rank #1 out of 11 high-income countries in our spending. That's our spending as a percentage of our gross domestic product. This is primarily due to our use, our consumption of high-cost technology. We have higher prices for items and services. And if you look at those two things, that's where the cost, that's driving the cost. What I always say to folks is follow the money. If you want to solve health care in the United States, follow the money. But the crisis doesn't end with cost. Access is also part of our crisis. We talk about crisis and we also talk about equity. These are two different concepts. Access, think affordability, think timeliness of services, okay? So can I access services, do I have the means? Do I have the money, the insurance, a way to pay for those services? And then timeliness. Am I required to wait? Am I placed on a wait list? All right? Equity, there's access and then there's equity. Equity has to do with the differences in access based on income. And in the United States, we rank, let's see, I want to say we're dead last in terms of both access and equity. So again, equity is, there's such a disparity in the access for those in the higher income levels versus the lowest. And 12% of people in our country, 12% are uninsured. Oh, and here are my notes. Yes, we rank dead last in access and equity compared to the other 11 countries. Quality. We can get in here into efficiency, outcomes. We rank last in terms of efficiency, last in terms of what they call mortality amenable to health care. All right, so with preventative health care, early treatment, the mortality can be curbed. We rank last there. We are fourth in patient-centered care, and we are third in effective care. All right, but we do score more poorly in performance in chronic conditions. We do better with conditions like cancer. Okay. Politics. This is also part of our crisis, that healthcare has become the political football, and it is used as one of the #1 features in negotiations among politicians, and it's really, I think, to our detriment that that's happening. All this means instability. All right, and from my perspective, it is this instability that is the crisis. Okay, cost, access, quality, politics, those aren't the crisis. Those are the causes. Those are the contributing factors that has led to, as I said, in the last year, particularly the year to 2 years, we are now at a point of instability in our U.S. healthcare system. Insurance companies are pulling out of that ACA expansion. You hear about that. It's because of instability. They can't depend on their contracts that they're making with hospitals and the like. They can't depend on what they're going to be paid for services. So it's disruption, all right? And we're back to the Harry Potter images, and we have Voldemort. And those of you who saw the final episode of the Harry Potter series, if you've read the book, you know it culminated in this great fight between Harry Potter and Voldemort. And they're at Hogwarts, and Hogwarts is in rubbles all around the pair. And that represents the disruption that's going on right now. So whether Voldemort represents cost, whether he represents access and the fact that poor people cannot access healthcare in the same way that the wealthier can. He represents all that, and then all around him, as he and Harry Potter fight it out, is the rubble, the disruption that results. We have politics. I've already talked about that. We have the polarization. Each side relies on hyperbole, relies on exaggeration and nitpicks instead of relying on facts, research, and analysis. Legislation, we have rapid cycle, development, review, vote, revise, review, vote, where public opinion polls carry more weight than the careful analysis. Regulation is pulled from the legislation. Legislation is the law. The regulation is basically the rules by which these federal agencies operate by. They put out their regulations in a similar rapid-fire manner, race to release regulations before a change in administration. Business financial decisions focus on the short-term profit, market share. The technological updates, while they're wonderful, they outpace paradigm, they outpace culture, they outpace our resources needed to fund them. There's no signs of improving anytime soon. We must have a planned, aligned response from our politicians, our businesses, our government leaders, and a response that addresses root causes. Again, follow the money. All right. The next slide, I'm going to be getting into one aspect of the disruption, the one aspect that concerns my daily work, and it is regulations. As I said, regulations arise out of laws. So, for example, the Affordable Care Act, that is a law that gave rise to various regulations that are promulgated primarily through the Centers for Medicare and Medicaid Services, which is our primary governing body and what we do. So regulations, well, let's look at the Affordable Care Act for a minute, okay? Lots of folks call it Obamacare, some call it the ACA. It's the Affordable Care Act. We're talking about 13 major changes, sometimes called provisions, It was enacted in 2010, but the provisions came into effect in a rolling manner year by year. So each year the regulations are released. So the Affordable Care Act is the law, leads to the regulations that are released over time. And they're still being released. And they're, when I say released, I should qualify that. They have been released, but their effective dates extend. So the related regulations have been released, but the effective dates, the last one I know about is 2023 that we will have to adhere to. So they're coming down in a more rolling fashion. So while Obama has left office, the effects are far-reaching. In fact, I caution each of you about passing judgment on the Affordable Care Act, whether you right now love it, hate it, or are taking a wait-and-see attitude. And it's deserving of all of the above. But I would encourage everyone to kind of give it some time. We will not see the effects of the Affordable Care Act until a decade or so down the road. Earlier in a previous slide, I said some of the financial numbers I was showing you were 2013. I chose that because the Affordable Care Act came out in 2010, and its regulations happened after that. So Medicaid expansion began, I don't know if it was the following year or 2012, but we had Medicaid expansion. We have some tremendous changes happening in this list that I'm showing you now that are happening over time, to where the financial impact of the Affordable Care Act, we don't know. We don't know. So it'll be interesting, as that Chinese proverb or the Chinese curse, may you live in interesting times. So eligibility, financing, IT systems, coordination with exchanges, that has to do with the marketplace insurance exchanges. Medicaid has to coordinate what they do with those. Benefits, the nature of the benefits that we have for our enrollees, the quality of care, dual eligible, that's a whole topic I won't get into. Providers and how we pay them. The transparency, I mentioned those managed care organizations that are increasingly managing or acting as payers for our Medicaid patients and their services. Lots with transparency to prevent waste, fraud, and abuse, prevention of those health problems that are killing us, long-term care. We've got our baby boomers. That number, population is growing. They're going to need long-term care and in children's health. So each of these represents a category of regulations that we are grappling with on a daily basis in Medicaid. So now Chapter 3. I know I'm covering a lot. Medicaid and public policy analysis. Let's talk about the problem. So now I'm going to really pull you all back to a more micro level. We've talked about the macro. We've talked about the environment. We've talked about the what's happening at the national level and what Medicaid is all about. But now I'm going to ask you to really shift, because we're going to talk about what is policy analysis and all this. What does it mean to do policy analysis work? What does it mean to do that for a Medicaid state agency in the current times? All right, so now Department of Medical Assistance Services. Again, this is Virginia's Medicaid program. To give you a little context, we're one of 11 agencies reporting to the Virginia Secretary of Health and Human Services. We have about 550 full-time staff, and we have the largest annual budget of any state agency, which is about $9 billion annually. That's the money that the state, that's the state's part. Remember I mentioned there's a 60% of services are covered through federal government monies, 40% state. That $9 billion is our 40%. The approximately 550 staff work at the agency. We're all under one roof. Heavily analytical teams of people. We range from, we investigate allegations of fraud and neglect. We develop and manage a huge information management system that tracks the, over 1 million persons on Medicaid in Virginia, as well as the managed care companies. We manage appeals of coverage decisions. We monitor and manage dozens or so of managed care contracts, oversee the development and implementation of various programs and projects that address special populations like long-term care and like the current opioid crisis as examples. Now, one thing you want to know about DMAS is, like a lot of companies across the company, private and public, we've experienced a lot of decentralization in recent years. Change is happening so fast, and so increasingly in what we call divisions, you all probably call them departments where you work, but our whole thing, we're the department, and then we have discrete divisions. I think we have 19 divisions within the department. And increasingly, they've taken the policy analysis work. So the analysis of those regulations and those laws that are coming both from the state and from the federal government, and you have different divisions kind of doing their own work. It allows them to have a more speedy response, a more flexible, agile response. But you can all guess the downside is silos. I joined DMAS about 11 months ago as an operations manager over the agency, the overall arching agency policy research division. I have a team of 6 analysts. Our customer is the senior leadership, okay? Policy analyst. In a nutshell, we surveil legislative, regulatory news and information that's coming primarily out of the federal government. Now, and I'm speaking of my team in particular, policy analysts work all across the sectors, and they surveil lots of different things. What my group does is we're really surveilling this legislative regulatory information I've been talking about. We make recommendations and funnel that information to our leadership to plan institutional responses. We analyze the potential impacts. Based on decisions made at the leadership level, we're going to be implementing the new or revised policies and then evaluate the effectiveness. I found this description on the Virginia State HR information. I'm not going to read it. I just want you to look at some of the verbs there. Develop, implement, interpret, research, analyze, survey, advise. Those are the functions of the policy analyst. The analyst, and there we have Hermione Granger, hard at work in her lab. She likes the quiet. She's smart. She's got her book in front of her, and she kind of represents the average analyst in my team, but not in age. All right, the average tenure of the analysts on the team that I inherited is 15 to 20 years. You know, I know 2 of them. DMAS is the only place they have worked. They are researchers. They are quiet. They are thorough. They are perfectionistic in their work. And they have unbelievable Medicaid and institutional knowledge, all right? They're brilliant people, and they know Medicaid law, policy, backwards and forwards, chapter and verse. Our leadership's impression of these folks is a concern. They are slow, indecisive, siloed, I mentioned that. And probably most importantly, their product has little value. So we're talking about individuals who there was a time when the expectation was for them to take their time to do very careful, thorough research and produce analysis reports that might be 30, 40 pages long, right? So these are your stereotypical researchers, professors, okay? And it had become a problem. Because as I mentioned, across the agency, there was the decentralization happening, where we have analysts all over the agency who are kind of doing their own thing. They all tend to have these personality characteristics. But my team, which was charged with having these sort of overarching viewpoint of the entire agency, particularly had some of these attributes. And here was our leadership. This displeases me. All right, it was not going over well. So when I came on board, I was charged with change. Okay? So after collecting information from my leadership on what their concerns were, I next turned my attention to my analysts. And here's what they told me. There's a lack of direction. They don't have the tools or the training that they need to meet these speedy, agile kinds of expectations. They felt adrift. All right, don't let the muggles get you down, Harry Potter. They really, the morale was low. They knew that they were failing, but didn't quite know how to fix it. They felt like nobody was talking to them. So, the solution. All right. So, working with the leadership, I came up with the purpose statement that our team, we were there to ensure an agency-wide aligned response to new or revised federal regulation. Leadership wanted that speedy, agile, decisive, and aligned policy analyst. They wanted somebody who was moving out in the world, talking, making recommendations, figuring things out, and moving much more quickly. They wanted to take the research reports and put them in the trash. We got down to behaviors. They wanted activity updates, both written and oral. One thing that the leadership told me, they wanted more face-to-face. Forget the report. Let's sit down and talk face-to-face about what's going on the federal scene. They wanted clear and concise recommendations. They wanted templated and shortened reports. They wanted that department-wide vantage point, so the whole agency. So they wanted our policy analysts to be going out and interacting with the other analysts throughout the agency, kind of collecting and summarizing that information, packaging it, with very quick turnaround for their leadership. Such solutions do require an innovative response. Innovation, and this is my definition, a significant, positive, and intentional change. It's repeatable, it's replicable, it is planned, it is deployed in order to solve a defined problem, need, or desire. And I borrowed that from things that I saw online. You know, if you go online, you look up innovation, you'll get 100 answers. But I liked this one. I liked that it emphasized that it's planned, it's intentional, repeatable, replicable. So we set out to craft our innovation. Again, you're going to recognize some of the Baldrige themes here, capabilities and capacities, our human resources. Do we have the capability, the skills, the experience, the education, and do we have the capacities, literally, you know, the space, the tools, and so forth? Do we have enough staff? Do they have the right education level? So we identified, through working with leadership as well as with the analysts themselves, we identified very specific capacities that needed to be developed. And these centered around technical writing. A lot of my folks were very rusty on their technical writing. They could write very well academic research supports, but by technical writing here, I'm talking about something much more short, to crisp, to the point. Something that can be consumed by the reader much more quickly. They needed skill. These are a group of introverts, very quiet, methodical people. We had to look at running meetings and really get very specific about the kinds of skills needed to run a meeting effectively. That relates to public speaking. Remember that I said our leadership wanted face-to-face contact with the analysts. They wanted to sit down and talk things through. So by public speaking, that's really what I'm talking about, the ability to sit down with executive leadership in small groups, and share cogently, very clearly, your summary and your recommendations on policy. We instituted SharePoint in January of this year as a tool. This was done across the agency, but because I had had previous extensive experience with SharePoint, I was really able to launch it very effectively for my team and get everybody on board with using it to collaborate and store and share important information, particularly with leadership. We also did some training in MS Project, keeping it very simple, very high level. We didn't get into the weeds with MS Project, but really used it to create timelines for projects so we could track accomplishment of goals and so forth. And then finally, performance evaluation. We, with input from my team as well as leadership, we crafted a revised job description that incorporated all these capabilities and capacities, and then launched a more formal kind of coaching performance evaluation system with the team, which involved a lot of one-on-ones and very specific, very timely feedback. Okay, focusing on the people, I just mentioned job descriptions and performance evaluation, lots of coaching. And the coaching went beyond me. I brought in knowledge experts from other points in the agency to talk on very specific kinds of skills like project management, like the budget process, technical writing. Two of our senior leaders came in and did some training with the team. We've had some transfers. Two folks have elected to leave the unit. One of them is very much part of a coaching, and it had a positive outcome. The individual went to a different unit in a different kind of role that was better suited for what she wanted and was able to do. And another one of our 6 analysts has left the agency on good terms. And that's a real ideal kind of arrangement. Folks can either change and shift or facilitate a good kind of change transfer. Processes. Oh, I love processes. I have a lot of ISO experience, and I love those processes and the documentation. We have documented our key work instructions, and they are available on SharePoint. Created templates. For those technical writing reports, we now have templates, templated agendas for meetings, the use of team calendars, process mapping through Visio and disseminating that work. These have all now become part of our daily work. Before I go on to outcomes, I did want to say something about culture. Culture is also important. When I took over the job, I had people on my policy analysis team who worked from home and even one individual 3 days a week. And work from home is very common in our agency. Again, back to culture. We have a very flexible work schedule, including work from home. But for my area, and given the problems and given the challenges that we were attempting to grapple with, we had to revisit work from home. And now my individuals work from home 1 day a week or none at all. And in all cases, in no case did I have to come out and say, you're not going to work from home anymore. Rather, it was done through coaching and just talking about, here's your responsibilities, and it looks like you're struggling with getting these done. Because remember I said, one of the customer requirements was face-to-face time. We needed people available and there. So that was one change that happened that kind of gets that culture. Okay. Outcomes. And I'm almost finished, and then we can turn to some questions. We are measuring time frames for project completion. We're using our Microsoft Project. We've also have developed some dashboards that we share with our leadership. And we're measuring our time frames for project start and then through milestones and completion. We're also doing some satisfaction, soliciting satisfaction information from our leadership, from the team members themselves, as well as the partners, which has to do with the other divisions that we're working with. Okay, and those are ongoing. I don't have data on that as yet. I started my work with the team in January, and so some of these changes have been more recently deployed. Okay. And that's what we've been doing at DMAS. So I know that I hope there are questions. I kind of missed having more of a back and forth, but that's the way we have to do it. Again, there are some references at the very end. I believe those links are all live. Well, I don't know if you'll get the links or not, but you'll have access to the slides, is my understanding. My contact information is there. You can certainly email me if you want more information, and I could send you some of the reference information. But I will turn it over now to the host. I guess, do I stop sharing? I stopped sharing.
Hey, Rebecca, yes, you stopped sharing.
Okay.
So thank you very much for this amazing presentation. Really gave us the perspective of how things are working in government agencies, especially Medicaid, where you have been involved, and all the improvements that you have achieved, ranging from organizational culture and being some process and project methodologies, as well as the people management component. So really, really thank you for all that you have done here. So I invite participants to pose their questions, and I'm going to be reading them out loud so everybody reads it, and also our presenter can answer the question. So the first question comes from Afshin Shamishi. Question is, are you experiencing any major roadblocks against your work? If so, what appropriate strategies you have already picked?
Okay, in short, yes. I'll start with the surprise, the pleasant surprise, is my roadblocks, first of all, have not come from leadership. This project and the way that I constructed it and have set it up it is leadership driven. And you'll notice that you picked up from the slides, these are the leadership, they are our customer for our team. The leaders are the customer, what we call the executive management leader team. And so I solicited very carefully their very specific requirements for what they want from our team and need from our team. So they are very supportive, aligned, they have my back all the way. The second thing I will talk about is the other divisions. So the folks outside of my immediate team, they have been very, very accepting, very enthusiastic about the changes that have been made, particularly in a passive sense. So what I mean by that is they're very excited to see that we're more prepared for meetings and that we're meeting deadlines, and that we're jumping in more assertively with recommendations. Where there is more holdback is the use of technology. So I mentioned SharePoint, and we are ahead of other teams in the agency in our own use of SharePoint. Well, it's hard to collaborate with our other divisions when they're not using SharePoint too. So that is a roadblock. And then finally, the real roadblock has actually come from the team members themselves. That has been challenging. They have been resistant. It's mostly passive resistance. These are introverts after all. But I have dealt with a lot of resistance to each change that I've implemented. They're very stuck in their ways. And that's why I mentioned, I mean, two of the 6 have already left. One of them is doing really well. There's been some fear, but she's doing well, and the others are more in the middle. So it's a long answer, but most of the resistance, I say fortunately, because so often resistance can come from leadership, which doesn't work at all. So that's been a blessing.
Great. Thank you, Rebecca, for answering the question. Also, we have still some few minutes to answer any other questions. Feel free to ask that. Action set. Thanks so much. Okay, so as we're leaving the time. Okay, so maybe Rebecca, let me ask one question based on what I've been following the discussion and the presentation. Is you mentioned that you were also a judge or an evaluator for Baldrige. Can you tell us how have you any specific example that you have used Baldrige criteria to apply to the government agencies?
Yeah. So the question was, am I applying any of the Baldrige criteria and Baldrige principles in the state agency where I'm at?
Yeah, or my question is more about the methodology itself, right? So, is there any particular components of Baldrige that you found really useful to apply in the day-to-day work?
Sure. Well, it's hard to pick one, but Baldrige is like part of me. And I'd say that collection of customer requirements and the way that I went about that in very systematically, starting with the vision and mission of the organization and really, talking to my executive leaders about that. I bring that up a lot in my team meetings and my interactions. Why are we here? What is our purpose? I'll tell you one of the things that what are your customer requirements? How do you add value? That really resonated with my team, by the way. If I talk about innovation, process improvement, neither are eyes glaze over. But when I would talk about how do we add value, how do we become valuable to our agency, that really perks them up. So I think a lot of it is in building those requirements and helping people think in terms of customer. That's also kind of new for my folks, is to think of the leadership and the other divisions as our customers.
Perfect. Thank you so much. And we have another question from Matt Harris. The question is, what would your analysts regard as material innovation or transformation of the industry?
And our analysts, okay, so I just heard a presentation on this today, so I'm going to talk about industry, meaning the industry of Medicaid and healthcare insurance. We are moving in our IM system. We're doing something very exciting in Virginia where we're moving from a kind of centralized, they call it kind of a monolith IT infrastructure to modular, building a modular system that is scalable and where these pieces and parts fit together to create the Medicaid IM system. That's very innovative. We're going to be one of the, if not the first state in the country to implement the CMS certified modular system in IT for Medicaid. I don't know if that answered the question, but it was top of mind for me.
All right. Thank you. There's one more question from Action. Is there any chance to get access to the presentation? And yes, I can answer that question, maybe partially. So this webinar is going to be uploaded in the next few days to our YouTube channel. You can, in YouTube, just search ASQ Innovation, and you're going to see this webinar as well as our past webinars you were not able to attend. But if there is any particular request for PDF or anything like that, I'm sure that that could be delivered.
Yeah, I mean, I have no problem with it. So, however you would want to make that happen, I can make those available.
All right, thank you. All right, so I think we covered all the questions. Just one more time here. Yes, and I think we're good on time. So again, thank you very much, Rebecca, for the wonderful presentation. Definitely informative and always helpful to hear the experience from the ground and see how quality professionals are applying different tools to innovate and to improve the organizations that we work in. So thank you for all the participants to joining this webinar. And again, this webinar is going to be uploaded into our YouTube channel, ASQ Innovation. Just search for that channel. All right. Thank you very much, everybody, and have a good evening.